Okay. So, good evening, everyone. I'm Talah Nammor. I'm a fourth year medical student, and you can say it.
I'm Momo, and I'm also a fourth year medical student.
And we're really excited to give you today's cardiology review session. So, how it will work is that we're gonna give you a question, and we're gonna wait for you guys to answer it, and then we're gonna explain why the answer is that way. Okay. So let's start.
Yeah.
Are you guys ready? We want a lot of interaction today.
You can answer on chat too. We have it open.
Yeah.
Let's get this started.
Okay.
Okay, so this is the first question.
It's started with a calculation. I'm sorry, but calculate the cardiac output from the diagram below. And you have these values given. So take your time, write in chat if you want, your answer.
Okay, we have our first answer. Okay, so we're getting a lot of C's.
C 1.5. Okay.
And the correct answer is C.
Good job.
So, okay, can someone come and explain why did you guys choose C? Or how did you calculate it?
300 over 0. Does anyone know the name of the principle that you're using? Yeah, good job. So someone said fixed principle, and basically, so I have the slide from your lecture in the next here. So basically, you're trying to calculate cardiac output using this principle. Remember this for your exam because we got an SAQ on our exam. I still remember it. But so basically, if you go, can you go back? Yeah. Here, the most important thing to remember from here is the formula itself. So if you have oxygen consumption, you have to do it divided by the arterial oxygen and the venous oxygen. So they're different. And the main important point here is to focus on the units. Make sure that you're always doing doing it in milliliters per milliliter. So for example, for oxygen, it's 20 over 100, right? So that's 0.2, and then for 40 over 100, you just divide them over each other to get the actual value in milliliters. And then that's it. So you do 300 over 0.2, which is their difference, and you'll get the answer in milliliters. You just convert it to liters by dividing it by 1,000, and that's it. That's the general rule. Do you guys have any questions for this?
I have a question.
Yeah, go ahead.
So why we didn't say 40 minus 20? Why did you convert it?
Okay, so like I said, the most important thing here, and he had it in red with the
yeah, we will send it after.
And yeah, so the main here, can you see the ones in red? It says per milliliter. So here in this question, or the questions he actually gave you in the lecture too, it says per 100 milliliter. So you just try to do 20 over 100, which is 0.2. Like it's the same thing. Just try to keep. Did you get that? Just try to keep it under milliliters, whatever the number is.
Yeah, okay, got it. Thank you.
Okay. No problem. Just be careful of that.
Do you guys want us to move to the next question, or do you have any other questions? I'll take this as a yes. You can move on. Okay. So a patient is given a drug that shortens the duration of phase 4 of the slow response action potential in the sinoatrial nodal conduction cells. Okay, which of the following changes to the as a result of to the resultant cardiac contractions would most likely be produced from this drug? So what do you think this drug would have an effect on the cardiac contraction themselves? So will we have no atrial contractions? Will we not have any ventricular or atrial contractions? or we're going to have decreased frequency or increased frequency. Okay, I'm saying a lot
Everyone.
of E's. Can someone explain why?
May I?
Yeah, sure.
Yeah.
So when you
Yeah.
when you
Yes, go ahead.
shorten the duration of phase 4, you make the action potential go much faster. So it will increase the frequency of the contractions.
Okay, that's perfect. That's exactly what happens. So basically, it's really important. I even like highlighted it to know that we're talking about the phase 4 of the sinoatrial nodal conduction. All right. So basically, if you can see in this image here, the 4 is beside the 0, and like here you can see 4. So how it usually is, for every AV node like action potential, we're gonna have a contraction of the heart. So if we decrease the amount of like if we decrease the duration of 4, we're gonna have more like contractions. Right? Is this clear?
Is this clear for everyone?
Yes. Okay.
Wait, I didn't get like how the answer is C. I'm sorry, E.
Okay, I'll explain. So basically, they're asking what is the effect of, like they gave the patient a drug, okay? This drug, it will decrease the duration of phase 4 in the sinoatrial conduction cells, all right? Phase 4 is basically, can you see the orange graph? So phase 4 happens like it's kind of like the repolarization phase or like the relaxation phase. So if this phase, so basically what happens is we're going to have an action potential of the sinoatrial node, and then we're going to have a little bit of relaxation. So this like action potential will correspond to a heartbeat or a contraction, all right? So if you can imagine it with me, it's going to be like this is an action potential, and then we're going to have like a period of rest and then another action potential and so on. If you decrease the 4, which is the period of rest, we're going to have more contractions of the heart. So what happens is we're going to have increased frequency of atrial and ventricular contractions, which means we're going to have more heartbeats or more contraction of the heart. Is it clear?
Yes, thank you.
Okay, you're welcome.
We'll
Okay, move on.
Okay, so the next question, the tendency for edema to occur will be increased by which condition? Arterial or constriction, increased venous pressure, increased plasma protein concentration, or muscular activity? A, C, 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 B.
Okay, can you guys explain why are you choosing the answer? Just like one word.
Yeah, for anyone, like if you want to explain your answer, go ahead.
So
we
most
can
of you guys
explain.
are saying C. Why is it C?
A or C,
hate the
hydrostatic
camera.
pressure. Yes, yeah. It's wrong.
Because the camera is horrible.
Oh, is plasma considered interstitial fluid? No.
C.
I'm sorry. Okay, so whenever they say plasma protein, they mean whatever's in the blood. So I feel like you want to change your answer if you know that, because interstitial fluid protein is something else. Is B hydrostat because of hydrostatic pressure? I'll just go on. Yeah, because I'm seeing a lot of answers, but whoever said, yeah.
So whoever said
B is correct. Good job. But someone said it's because of hydrostatic pressure. That's right. So like do you all remember? Okay, wait. What's the name of the forces? Like there's a name for this law. Do you all know what that is?
Starling forces?
Yeah, good job. So it's Starling forces that I want to talk about here. And Starling forces basically, if you remember from your lecture, it's affected by 4 different forces. You have capillary hydrostatic pressure, plasma oncotic, which is the plasma protein pressure. It like drags water inside the blood vessel. And then you have interstitial oncotic pressure, which is the pressure in the interstitium. and interstitial hydrostatic pressure. Now, hydrostatic means like the fluid of the water or the fluid in general. The question here was asking what causes edema. So in that and in other terms, that means what causes. Oh, it's okay.
Sorry.
What causes fluid to go out of the blood vessels into the interstitium? So let's say, for example, arteriolar constriction. If arteries constrict, like arterioles in the capillaries constrict, will there be fluid, like passing through the arterioles? Will there be pressure? That's what I'm saying. Like, will there be enough hydrostatic pressure to cause edema? No, yeah. So that crosses, like, you can cross out A. For B, increased venous pressure, that means from here you can see that increased venous pressure. So on the other end of this, like, I don't know if you can't see it, there's no pointer, but the other end of the capillaries is the venules or the veins. So imagine like the veins are like compressed, there's more pressure on the veins, that means there's increased resistance. That kind of pushes blood back into the capillaries, you know, like it doesn't let the blood go. Yeah, it's okay. It doesn't let the blood go
I just want to try
from
to
the
see if we
capillaries to the veins, like to the rest of the body. Okay, so the blood is stuck in the capillaries, kind of. You can think of it that way. So this causes the hydrostatic pressure, like someone said, to increase, which causes filtration and edema. So is that clear for everyone, what I meant by that? By the veins being like high in pressure or high in resistance.
Could you try to explain it again, please?
Okay, yeah, sure. So so you have in a capillary, you have arteries, capillaries, and veins, right? Capillaries are, or like capillaries where every like exchange takes place, and you want the maximum like amount of exchange to take place. Imagine in veins, if the pressure is high or resistance is high, like it says here, so the veins are like this, right? So the blood, most of the blood will go in the capillaries, like they'll stay there. They won't be able to flow through the veins and go back to the heart. So that's why this backup of flow in the capillaries or increase in hydrostatic pressure will increase the forces of the blood vessel to go out, of the blood to go out. Do you get what I mean? Like, does that make it more clear?
Yeah, it's clear. Thank you.
So it's the opposite of, like, for example, if I say dehydration. So dehydration means you have less fluid, so less hydrostatic pressure, less edema chances. So if in any case it increases the fluid, like the pressure in the blood, that means that you have more edema, like possibility of edema. It increases that means that you have more Okay, is that clear for everyone? Why? So it's based on your slides here. So what I mean by pressure is it's the same thing as saying resistance too, because they're directly proportional. Is that okay? If not, it's okay.
we can repeat
I can
it.
repeat it. Yeah. What would muscle contraction of the, if you mean the veins, muscle contraction of the veins would cause this too. So it depends, honestly. Like if you're thinking about capillaries, it would be the same result as this. But if you're saying muscle contraction of the big veins that like cause, you know, the blood to go back to the heart, it won't cause edema. It will do the opposite because you're pushing away all the blood back to the heart. So it's different cases, if you want to think. So muscle, usually, like when we're talking about venous resist or Starling forces, we're talking about the area of capillaries, area of arterioles and venules. That's why. Does that make sense? Like you're talking about the big veins in the, like next to the heart. So what was option D? Okay. So option D was muscular. Yeah, it's not the right answer. Like, you get me? There are no muscle factors in capillaries or arterioles. That's why it's wrong. Okay. C, increased plasma protein. You can see from the next slide too, it's decrease in plasma protein because what they mean by plasma is in the blood. So there's less proteins in the blood, which means less reabsorption and then that causes edema. But the question said increased, so that's the opposite effect. So make sure you know the difference between that. Is everything okay? Like, you want me to explain this again? I don't mind. Okay,
Okay,
I hope
perfect.
so. Because
Alright.
starting forces is one of the most important topics. Like, if you did hemodynamics too, it's like it's half of the lecture. So
Yeah, you're gonna get a lot, not a lot, but like a fair
like,
amount of
yeah.
questions from this.
Okay, I'll repeat. So I wish I got a better diagram, but basically for starting forces, these are the four like category of four factors like you need to make sure, like you need to understand. So let's say there's decreased, so there's arteries, there's arterioles, capillaries, and yeah, high yield. Yeah, so arterioles, capillaries, and venules. So whatever affects the arteriolar side, if let's say for example there's decreased arterial resistance, means that the arteries are like dilated, they have less resistance, they're able to hold more blood, so they're dilated, right? So we have more fluid, more blood coming into the capillaries, that can cause edema. That's the first point. Okay, second point is venous. So let's say arteries are dilated, it can cause edema. What about the veins? If the veins are compressed on the other side, then that can also cause edema, because now
They're
all the
pushing
blood,
the
yeah,
blood.
they're pushing
So
the blood into the
usually
capillaries.
you know how basically the veins are the reservoir of blood, and how we basically have like, because the veins, they don't have like, their lumen is wide and they don't have
Yeah.
their own like muscles which they can like keep the blood flowing all the time. So basically veins, if they don't have like muscles around them pushing stuff, so what happens is the blood is gonna stay there. So if we have like a lot of blood, then not like it won't seep into the surrounding, so we're not gonna have edema, because this is how it usually is in the vein. But if we have like a force that's causing the vein to like kind of like be
Yeah.
very tight, then everything is gonna kind of like go out, if you can imagine. So basically, if the vein is like, usually the vein is like this, and it can allow, like we have here a lot of fluid, okay, the blood, and then that's how usually it is. But if we're like pressing the vein, then all the fluid is gonna go out, and this is gonna cause edema.
Yeah.
And how is it going to become this way? By increasing the resistance of the veins, because we know that veins usually have very low resistance. Why? Because of the way their wall is, how it's not made up of like very, like it doesn't have a lot of elastic
Yeah.
fibers, it doesn't have a lot of like muscles. So yeah, is this clear?
Is that better? Okay. Okay, before
Wait,
yeah, go ahead.
I just want to check.
Before we go ahead,
So whoever's
yeah.
called phone,
No, yeah.
the person, yeah, who asked us to repeat, is it clear? We don't want to like go to the next like question without making sure that everyone understands this. Okay, perfect.
Okay.
Now next.
Yes.
Okay. So an increase in arterial resistance without a change in any of the other components of the cardiovascular system, what will it produce? C.
See. Does anyone have any other answer? C,
And can someone explain
D.
why C or why D? We want to know why are you guys choosing whatever you're choosing. So we just make sure that you guys are choosing it for the right way. Because more resistance means more pressure. Do you guys agree? I chose D because more resistance means harder to push. Interesting, I guess. Okay, so the right answer is
Press it. Yeah. Yeah.
C. Okay, so basically, whatever they said that more arterial resistance means more pressure, that is true. because imagine it like a balloon. If you guys add resistance to the balloon, or like think of it this way: arterial resistance means we have like more pressure, like not more pressure, like more something that is squeezing the artery more. So think of it like a balloon. If you squeeze it, then the pressure is gonna be so high it's gonna pop. So it's just the same way.
Yeah.
But it's the artery is not gonna pop. It's just you get it?
Yeah, this is correct.
Wait, he was like saying more pushing force need, so systole would be harder. Yeah, but this is like
based on the formula too. Like see, what do you call it? Pressure is cardiac output times resistance. Just know that pressure and resistance are always directly proportional.
yeah, so whenever we increase resistance, we're gonna increase pressure.
Oh wait, you have to.
Oh yeah.
So
this is this is the formula. So the mean arterial pressure will always equal cardiac output times like the total peripheral resistance. But if yeah, so since they're all in the same line, like it's like math, you know, if they're all together, then that means everything is directly proportional. But if it's like something is above the other, then it's inversely proportional. Is it clear?
Okay.
Okay, moving on.
Next question. A 55-year-old man presents with complaints of dizziness and shortness of breath on exertion. The physician detects a heart murmur heard during the portion of the cardiac cycle labeled X. You guys can see there. Which of the following heart valve pathologies would most likely produce this murmur? Okay, B.
Guys, always
Does
write
anyone?
why.
Yeah, just like
Please.
short answer, like why.
Yeah.
B is the only one with diastolic.
heart murmur. Interesting.
Okay, everyone said B.
B for boys.
Yeah, everyone got this one right. So it is mitral valve stenosis, and like someone said, it's the one, the only one in the list here that's a diastolic heart murmur. So my main goal from this question for you is for you guys to understand which part is diastolic and which part is systolic. So if they give you a graph like that, the point, like, I don't know if you can see, but the two like gray outlined areas is the systole, where the pressure rises up and so on. But everything that's marked in X is diastole, which means like the heart is relaxing. So in this phase, like all the valves, either stenosis or regurgitation, have their own, like they have their own time when it happens, right? And the most like time that mitral valve stenosis shows up, or you can hear it, is in diastole. And do you know how it presents? Like, do you know what it's called? Did he teach you like how it looks like on the diastole? Because once you see that, yeah. Wait, can you go down for this one? Yeah. Okay, if anyone does, like, if he didn't teach you, it's fine.
She's writing to Baba, and so she said, "You only do one message," and so she does a lot of messages.
قول لها انا قالت لك خليني جيبوا التليفون قاعد تتكلم في التليفون ماما انتوا
Wait, someone's unmuted.
Okay, it's fine.
It's fine, yeah. Okay. Anyways, so it's called an opening snap, but that's how you can memorize mitral valve stenosis. That's it. All the rest, aortic stenosis, pulmonary valve stenosis, tricuspid regurgitation, mitral regurgitation, they're all in systole. So that's
Can I ask a question?
Yeah,
sure.
go ahead.
If the point was in LV, would it be considered a systolic murmur?
If the point, you mean on the graph LV, like here?
Yeah.
Yeah, that's systolic. So whenever, like, you know, the point where the graph rises up, anything from that point is systole. So that would be considered a systolic murmur. You're right.
Okay, thank you.
No problem. Do you guys have any other questions? Like,
I have
this
a
is
question.
yeah.
Sure.
So how can we differ between the systole murmur and the diastole? How can we understand it rather than just memorize?
Oh, honestly, for this, like, I used to memorize. So there are ways you can understand it, because, for example, in what do you call it? In diastole, I'll give you this example. So in diastole, the heart is relaxing, right? Which means that the blood is going from the left atrium to the left ventricle. Like it's all like going, like the valves are open. So when you have mitral valve stenosis, which means like the valve is narrowed when it usually should be open, that's when you hear the most sound. So in diastole, that's when you hear it. Aortic stenosis, for example, when the heart is contracting in systole, the heart is trying to push it out of the blood through the aortic valve, right? This is during systole. So when it's narrowed, again, you will hear it most in systole. Does that make sense? Does it
Yeah,
make
that makes much more sense. Thank you so
Yeah.
much.
No problem. Does anyone have other questions? Can you
Okay,
do it?
just finish pathology.
Oh, okay, I'll try. But okay, so let's say all of these are systole, by the way. I don't have for like the rest, but let's say tricuspid regurgitation or mitral valve regurgitation. In systole, you're trying to push blood again outside of the heart. So which ones are open? Aortic valve and the other pulmonic valve, right? So in so that means that how do I say it? So like when you're trying to push it outside of the heart, and the valve, which are mitral and tricuspid, they are loose, like they're open in that part in systole. That's when you hear it because they're supposed to be closed. In that part in systole, they're supposed to be closed. Does that make sense? For D and E. For pulmonic valve stenosis, just remember that as aortic valve stenosis. So they're narrowed when they should be open in systole. That's why. Okay, is that
That's
clear?
perfect.
Yeah. For everyone. Wait.
Do you
can
guys
go
have
down?
any other questions? Yeah, it's done.
No.
It is done. Do you want us to move on to the next one?
But I think those are most of the pathologies like I covered, right?
Yeah.
Regurgitation stenosis. Yeah.
I think they won't trick you a lot with this question.
Yeah, but that's another way you can
Yeah.
memorize. Yeah.
So we can move on. The yes place is to move on, right? Not to repeat.
I think so. Yeah.
Okay.
Okay. But inshallah, that's clear.
Okay, guys. So
Go ahead.
atrial and ventricular rates can be determined by counting the number of small. I changed it.
It's okay.
Anyways, atrial and ventricular rates can be determined by counting the number of small boxes between. What do you guys think? The end of one P wave and the beginning of another, or two consecutive P or R waves, or the middle of two consecutive T waves, or the beginning of the P wave to the end of the T wave.
They're saying B, B, D,
Can someone explain why?
A.
B.
Okay.
Okay. So Saad said basically B because it's the time between them that shows either the time between each atrial contraction or each ventricular contraction. And Saad is correct. So basically, the question is asking for the atrial and the ventricular rates. So you have to keep in mind that basically from a P to a P, that's an atrial contraction, and from an R to an R, that's a ventricular, like atrial is from P to P, that's the rate, and a ventricular rate is from R to R. Can you guys imagine the like P, Q, R, S, and then this ST, okay? So basically from this P, okay, from a P to a P, this is basically an atrial rate. From an R to an R, that's a ventricular rate.
Is that clear for like everyone who said A? I think some people said A and D.
We just not choose A because basically A is only for atrial rate, okay? And D, the beginning of the P wave and the end of the T wave, that's basically only one, like this is a heartbeat, okay? So this is one contraction. That's like one full contraction. So that's like a heart rate, not like you can't like differentiate between the atrial and the ventricular rate. Do you get me?
Is that clear? If you have any questions, like
Yeah, don't worry about this.
Throw them at us.
We're gonna talk about this again at the end of the presentation. So I kind of changed the question at the end, like put it at the end, but then it didn't show up here. So yeah, I put it beside the ECGs.
Oh, it's fine.
Is it okay? I'm going to explain this in more details.
Yeah.
Okay, perfect. Okay. Yeah, the next
Oh,
question.
Oh, another wait, let me find it here.
It's question 12.
Yeah, question 12. So you're given all these values for capillary hydrostatic pressure and oncotic pressure. Yeah, and so what is the direction of fluid movement and the net driving force from these values? So I'll just someone calculated it already.
Oh, that was so fast, mashallah.
Yeah, so someone said
Unless if
B.
you know the question before.
Oh yeah, maybe. So P1 is P interstitial. That's sorry about that. But yeah. Hydrostatic pressure.
Can you move the small box? Oh my bad.
Oh, they can see this? I didn't know.
$32 minus 23.
Oh, thank you for explaining. That's so nice. Yeah.
So yeah, 32 minus 23 is 9. And it is correct. It is 9. But it doesn't only end there. We have to know if it's absorption or filtration. Which way is it going?
Because we showed them.
Yeah.
But
yeah, exactly. So it's positive, so it's filtration. I think this is clear.
This is like this is clear from the Starling forces. So this is what I wanted you guys to know from the last one. So you have forces that pushes blood outside and forces that keep it in. So forces out is the blood in general, the blood hydrostatic pressure with the not plasma proteins, the interstitial proteins in the interstitium. So they drag it out of the blood. Minus the forces in, which are the blood, the whatever fluid is in the interstitium, with the plasma proteins that drag the water inside, like that drag blood inside the blood vessel. So if you subtract these two, you'll get a number. If that's positive, that means the blood pressure is more than the interstitium, so like fluid will go out, which is filtration. And then if it was negative, if this was -9, for example, you would choose absorption. So it would go back into the blood. Is this clear for everyone? Like these? Okay, good.
I have a question.
Yeah, go ahead.
So I understand the concept, but I don't know how to differentiate between each of the given. So can you simplify names?
The units, you mean?
Yeah, the capillary hydrostatic pressure and interstitial hydrostatic pressure.
Yeah,
So
okay.
Can you give me a clue so I know which is in, which is out?
Yeah, sure. Okay, so hydrostatic, so you all know what hydrostatic like forces are, right? You have capillary hydrostatic pressure. That's where, so in these units, wherever you see C, small letter C, that's capillary. So PC is hydrostatic pressure of capillaries. The pi sign you see there, pi and C, that's oncotic pressure. So whenever you see that sign, that's protein pressure or oncotic pressure. And then you have PI. So whatever is I is interstitial. So PI means so PI means interstitial hydrostatic pressure. So whatever's in the interstitium, that fluid pressure like presses the fluid to go into the blood vessel. And then pi I again is the oncotic or the interstitial protein pressure. Is that so? Okay, wait. So they're both opposite ways. So the hydrostatic pressure inside the capillaries pushes blood out. So it forces blood outside. The one in the interstitium pushes it into the blood, inside the blood. Because it's in the interstitium and it doesn't want to be contained, so it goes to the blood. So they're opposite. So the hydrostatic in the blood vessel tries to push it outside of its blood vessel, so it goes out. Proteins, on the other hand, they like water, so they drag water wherever they are. So let's say plasma proteins, the proteins in the blood, so they want to drag water, so they try to, their force is in. proteins in the interstitium, they're forces out because they drag it outside of the blood vessel. Is that clear? More clear?
Yeah, thank you.
Okay, no problem. Can we move on to the next question, or is that okay? I hope that's clear.
Okay. So basically, a patient had an ECG at the local emergency department, and the attending physician stated that the patient had an AV nodal rhythm. So what do you think the heart rate is?
Oh,
40 to 60, 40 to 60. Yay!
Oh yeah, okay. So someone said, I'm assuming this is from the last question.
it
No
is.
fluid movement means 0. Yeah. So if you get 0, that means no net movement.
Okay. Guys, B is correct because as you guys all said, AV node rhythm is usually between 40 to 60. So if a patient's SA node is no longer working, what will happen is that the AV node is going to take over, and when it takes over, we're going to have basically a heart rate that is equivalent to the power of the like the AV node. Okay?
Everyone
I think
got
it's
this right.
very it's very easy. Next.
Okay. Following a sympathectomy, removal of sympathetic nerves, a 66-year-old man experiences orthostatic hypotension. The explanation for this occurrence is which one?
Tension rhythms, no? Yeah, it is. So basically, yeah, it literally is. So basically, if we don't have SA node, the AV node is gonna take over because it has like the strongest activity between all other things. If AV node fails, the bundle of His is gonna take over. And then if the bundle of His does not, it's gonna be like the Purkinje fibers. Anyways.
Okay, wait. Oh, sorry.
Before guys answering, a sympathectomy is basically removal of sympathetic nerves. So we don't have autonomic sympathetic.
Sympathetic.
No, we don't. Yeah, we don't have autonomic nervous system like activity on the.
Not autonomic. I think
Sympathetic is under autonomic.
Yeah, I know, but.
Oh yeah, it's sympathetic. Specifically
whatever.
sympathetic.
Because I'm.
Yeah.
Wait, people said C and D. Now that you know what it is.
Yeah. So if we remove the sympathetic, what does the sympathetic usually do? Does it prevent the baroreceptor or does it activate the baroreceptor? Now that we know what.
Like now that you know what I can't say it. Sympathectomy is.
So it prevents the baroreceptors. It activates.
Activate. No, she said. Wait, activate, prevent. Okay, activate. Okay. So you can see from the sign too, orthostatic hypotension.
So
that's not
decreased
normal.
hypotension.
Yeah, like.
Yeah, orthostatic hypotension is when a person just stands up and their blood pressure directly goes down.
Yeah.
So this is usually not normal. And this is due to.
Yeah.
Can I show?
Yeah.
It's a suppressed response of the baroreceptor mechanism. Exactly.
Yeah.
So usually it activates the baroreceptor mechanism. And if we remove the sympathetic nerves, what will happen? The baroreceptor is not going to be activated. So it's suppressed.
Usually, like when you so orthostatic hypotension means like the pressure in your body is like once you stand up, right? And you're not usually supposed to have hypotension because once you have decrease in arterial pressure, the baroreceptor usually responds like it responds in a way to increase sympathetic activity, right? But now, since it's cut, there's no activity, no baroreceptor activity. Does that make it clear? So that's why the answer is D, like suppressed. Supposed to stop discharging. Baroreceptor is supposed to stop?
How?
But if no signals, then shouldn't they try to like compensate by more activity? Or because it's.
But if no signals,
wait, can you explain what you mean by baroreceptor supposed to stop? Yeah, it is.
That's exactly what's happening. Because we removed the sympathetic system activity, usually the sympathetic is going to activate the baroreceptor mechanism, all right? So if we remove the sympathetic nerves, they're not going to get an activation. The baroreceptor is not going to work. So what happens is we're gonna have a suppressed or basically
Yeah,
like the parasympathetic nervous system will work all the time, and it's not gonna have anything opposing it. So it's just gonna be suppressed forever.
Yeah, I think
Yeah.
think one person got it. But
Isn't there
did you get it?
discharge to the
I think
activity
Humam,
when you get it?
whoever.
If there's this activity, the sympathetic activity increases. No, but
So-
we're saying that the
yeah.
sympathetic activity is gone.
Like,
Like
it's-
sympathectomy is basically they went and did a surgery where they removed the sympathetic nerves.
Yeah.
So we don't have sympathetic nerves. Okay, perfect.
Okay.
Are you guys sure?
Wait,
Yeah.
I want to ask if you got it,
Is there
Humam.
literally no fight or flight? Yeah, literally, there's
Yeah,
nothing
there is
because they
nothing.
removed the sympathetic nervous
Yeah.
system.
Okay,
I
good.
got it. Perfect. Let's go on.
That's it. Wait, the most important thing from this that question was just to let you know what baroreceptor, like how it works and what it's supposed to do. So it increases sympathetic in response to like increased pressure. That's it. Okay, we can move on. Oh wait, is it
That's
yours?
yours.
Okay, so an acute decrease in arterial blood pressure elicits which of the following compensatory changes? Wait. This is a similar question, by the way.
Yeah, it
I'm just
kind of
saying.
has, yeah.
Yeah.
A, because less pressure means less stretch, means less firing rate. Wow, guys,
Yeah,
you know
okay, everyone
this.
knew.
Yay!
Yeah. So it's exactly what. Oh yeah, it's
Is it?
exactly sorry. It's exactly what wait, Saad said. So less pressure means less stretch of the carotid, like sinus baroreceptor, and that's less firing rate of the carotid sinus nerve. So good job. Yay! So I think
Okay,
that's
moving
good,
on.
Yeah.
Myocardial injury is represented on an ECG. So we can see basically that the patient had an injury to his heart. So what do you think we're going to see? Will we see T wave inversion? Will we see ST segment elevation, pathologic Q wave, or ST segment depression?
I like this question.
Yeah. Why are you guys saying B? Someone explain.
Oh,
Or
that was
D.
a D. B.
B,
Oh, B.
myocardial infarction means ST elevation, so maybe this is the same thing.
I saw it in a show.
Because ischemia.
Okay, but most people are saying.
Okay, so basically it's B.
Yeah.
ST segment
So good job.
elevation. Why? Because basically, usually, if we have a myocardial injury, which means that we have.
It's okay, yeah.
Yeah, if they wanted, because D means ischemia and it's not injury, is it? Yeah, ischemia is basically another, like, okay, so there are like kind of grades for the injury.
Yeah.
So in the beginning, when we have basically a myocardial infarction, so what happens is we're gonna have prolonged period where we don't have enough blood supply for the heart. So what happens is we're gonna have the ST segment elevation, which will kind of like tell us, oh, these specific coronary arteries are not receiving any more blood. So yeah, for as you said, ischemia is like after the myocardial, like we have acute myocardial infarction, then we have something else, and this is like, guys, very you're gonna take this in third year, so just stick to this. Yeah. So if you have myocardial injury, we're gonna have ST segment elevation. Is it clear? Okay, can we move on?
Okay.
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 Okay, this question, it's mine.
Go ahead, read it.
Wait.
Yeah.
Okay, so basically the diagram shows the ions responsible for the current flow during the phase of the ventricular action potential. Which of the following identifies the correct current flow in the normal ventricular action potential? People are saying C, B. It's full.
It's up.
I need guys' explanation. Why do you think it's C, or why do you think B? Because phase 4 is related to calcium. Sorry, potassium, and the plateau phase is with calcium. Is it clear where NA or K is referring to? Wait, guys, look. So basically, no, like it's for phase 4. So the line, it's not the 0. The 0 is just a 0. There's no ions there. But the sodium or the calcium or the potassium down is for phase 4. So basically, when they say ventricular action potential, they mean the cardiac muscle, not the what is it called? The SA node or AV node. So most of you guys are saying B.
Yeah. Oh, it'll show up here. Yeah.
But the answer is C.
Wait, but
I think it's a typo. Yeah.
Yeah, maybe.
I think it's a typo. I think it's B because as you guys said, usually potassium. No, it's not C. It's wrong. I think there's a mistake in the heart. The heart shifted downwards. Okay, so basically it is B because we know that basically what is the thing that keeps the resting membrane potential? It's potassium, right?
Yeah.
So basically for phase 4 it's usually potassium, and then for the plateau phase it's calcium.
Yeah.
But the heart here is a mistake.
I think
okay,
maybe it's
I think it shifted. Okay.
Oh, really?
Yeah, maybe because from the slides to here. Is it clear? It's not C, it's B.
Oh yeah.
Because
That's
guys,
true. That's true.
Na will cause the depolarization.
Or maybe they mean Na on the 0 or
Wait,
something.
guys,
Yeah.
the sodium. Okay, I'll tell you something. First of all, this question, what is it called? It came from our final. We had this question in our final or midterm. Okay. Do you see like, okay, sodium, potassium, they correspond to phase 4. What is phase 4? Phase 4 is the resting membrane potential. So which ion corresponds to the resting membrane potential? Potassium. Okay. Correct.
As long
so
as
basically,
you know that. Like, yeah.
the only graph that has potassium is B. So I'm telling you guys, the answer here, it's like the heart is supposed to be a B, but it shifted down. So, okay, it's just a mistake here, but the correct answer is B.
We'll change it.
What makes it even, like, how do we know that it's actually B? Because the calcium is at the resting or the plateau phase. And we all know that what causes the plateau phase is the calcium. Is it clear? I'm sorry for the heart.
No, it's
Yes,
fine.
I just want to make sure everyone.
Yeah.
I think it's clear. We'll fix it,
yeah.
When we send it for you, we're gonna put it on B. Okay, perfect.
Okay. Next question. Carbon dioxide regulates blood flow to which one of the following organs as its like main control of. Someone said C. I'm assuming it's for this. But wait, it's not. C. The brain increases vasodilation when there increases carbon dioxide. Okay. Does anyone have other answers? Because this is like straight from your like slides. Like you just try to memorize this and the one for periphery. Okay, C. The answer is C. Yeah, everyone did it. So yeah, this is a picture from your slides. Main thing is just know that carbon dioxide is the main like thing that controls or affects controls the blood flow to the brain. So this is different from the peripheral blood flow. Okay, so for the brain, like Saad mentioned again, if metabolism increases, which means you have more carbon dioxide, there will be vasodilation, and that's what leads to control of blood flow. Is that clear for everyone? Just know that point from this slide, honestly.
It's kind of straightforward.
Yeah. Okay, good. Another one. So which one of the following vasoactive agents is usually the most important controller of now coronary blood flow? So these are just two questions from like right after each other. Everyone's like, okay, A, because the slides say that A. Okay.
Yeah.
Good job. So for cerebral, just remember it's carbon dioxide. For coronary, for the heart, just know that, wait, I just want to read it. So for the heart, just know that things like adenosine control, like they're the main vasodilators that control blood flow in the heart. Even though bradykinin, yeah, why not D or E? Yeah, so even though bradykinin or even prostaglandins and potassium ions they all have an effect in the blood flow for the heart, adenosine is the most one, and it says in the question, the most important controller. Is that clear? I love the name for this user, but yeah, is that clear?
You're interested in GI?
Adenosine, I know it says that on your slide, but it's also like it's formed as ATP is broken down, right? And small portions of that are degraded into adenosine. So as you see here, which is released, and that's it. It just helps dilate the coronary blood vessels more. Medicine?
Oh, I think the name is from medicine.
Oh, okay. That makes sense. But is this clear for everyone? Just know the difference between cerebral and coronal blood flow. And just know that adenosine is the most among all of the rest, like among all of them. Is that okay?
I think that's clear.
It is. Can you explain what
So-
B and C is?
I feel
for?
like B and C are just like,
they're also vasodilators, but they're not the main like controller
Yeah.
of blood flow. So prostaglandins, for example, if I'm not wrong, there's like a lot of different
yeah.
prostaglandin types. Like it can vasodilate like other vessels, not only blood flow. Bradykinin is usually for like it's for something else. I think it's for allergies, if I'm not wrong. So vasodilating skin, like the arteries in your skin. So not only the heart. Okay, adenosine. Yeah, so they're distractors basically. That's it. Okay, is that okay with everyone? Is it okay to move on? Because we have so much more questions. So many more. No, Chala will be there. Yeah. Okay, good.
Okay, next. This is a hard one. I'm excited.
Is it?
Yeah, so basically a normal ECG trace of one cardiac cycle and a normal recording of one ventricular action potential are shown. The wave on the ECG trace marked with a star most closely correspond to which phase of the ventricular action potential? So guys, what is marked? Let's start step by step. What is marked?
Oh, on the first.
Oh, can you see, like, it's the P wave. I gave it away.
No.
Yeah, exactly.
Okay, someone said.
It's the star at the P wave. So basically, can you tell me where does it correspond? It's right above the P wave. It's tiny. But can you tell us where does it correspond in the ventricular action potential?
Oh, it's not. I think he means that.
So is it A, B, C, D, E, F? C for cat, P is atrial contraction,
Someone said
F,
F.
F.
I love this question.
Yeah, I know.
Yeah.
Right? I'm like, okay, you guys are smart, and it's true. It is F because the question itself, it really said that basically a normal recording of the ventricular action potential is there. So basically, if like the P wave corresponds to what?
Atrial contraction.
Yeah.
Exactly. So the P wave corresponds to the atrial contraction. And the question itself says that basically, the question itself says that this graph in here is the ventricular action
one.
potential.
The down one.
Yeah, so basically without even like looking at the image, you can directly know that, oh, it does not correspond to anything in it. And you can see in here, like there is an image. This is like literally, yeah, from your doctor's slide. So you can, ECG is only for cardiac cycle, right?
Like the P.
Yeah, the PQRST is for the cardiac cycle, true. So basically you could see how basically the pink there corresponds with the P, and then the QRS will correspond with basically phase 0, 1, 2, 3 in the ventricle. So the P is not, so the ventricular, like ECG is not this, the ventricular action potential will correspond to QRS and T, but basically it will not correspond to the P wave. Okay, I think it's kind of easy.
Yeah, I feel like they got right.
Yeah, I
That's
thought it's
so
gonna be
good.
harder.
Yeah, me too.
I was excited, but you guys got it right away.
Which is good.
Yeah. Do you guys have
But-
any questions? The silence is deafening.
I hope not. But no, if you do, like, you can ask us.
Okay.
Okay, I think it's clear. I hope, I don't know. But if you have any questions, I forgot my question. It's okay, if you remember it, just let us know in the chat. It's fine. We'll come back to it. Should
Can we move on?
Yeah. Should we move on?
Okay. So
It's okay. I'll read it. So we can move on, right?
Yeah, yeah.
So under control conditions, flow through a blood vessel is 100 milliliters per minute with a pressure gradient of 50. What would be the approximate increase in flow if you increase the blood radius, like the blood vessel radius, by double, assuming that the pressure is the same?
E
because
doubling
doubling
resistance to the power of 4 equals 16.
Okay. Does anyone have other answers? Yeah, I know. Mashallah, mashallah. That's really good. And also the explanation. Okay, E.
So if anyone wants to say any other answer?
I feel like
B,
yeah, okay.
2 to the
B.
power of 4.
I didn't get it.
Get it.
Okay, so
No, you don't have an explanation
for what?
for this.
For B? Oh, an explanation slide? No, I don't have. But I just wanted to say, I wanted to draw the formula out, but this is from hemodynamics. Yeah, there is a formula. Someone said, isn't there a formula? Yes, there is. So if you didn't get the question, yeah, let's show the answer first and then I'll explain. So the answer is E. Whoever said
Do you
E
wanna
is right.
do you wanna like type it out or like give them
How? Like,
in-
oh,
Can you see the notes?
the-
Yeah, they do.
Oh yeah, that's so cute. Okay. Anyways, yeah, so basically what this question is saying that you have a vessel, right? And the only thing that changed in this vessel is the radius. You're increasing the radius, you're doubling the radius by 2. Now, if you remember and they want to, and they're asking what would be the increase in flow. So as you know, flow is, do you all know the formula? Flow is like the flow is pressure difference over, wait, if I'm not wrong. No, sorry. What was it? Flow is, I think it was times, yeah, it was like that, right? Flow, pressure difference, times resistance. Wait, oh yeah, I just got it. Okay, sorry. So flow, wait, is it like that? Yeah, flow is which is cardiac output, same thing, is pressure difference over resistance. Is that right?
Does this
Also,
have a
this is-
typo or something advanced during the pressure reading?
Oh, maybe that's why.
Oh, so no, isn't
Pressure gradient is maintained. Yeah.
isn't it double though?
No, the radius is double.
Maybe that's why.
Yeah, maybe. Sorry, I don't know. I copied this question from a source though, but anyways, it's fine. So I'll fix that and I'll send. But you can see that pressure gradient is maintained, so that means that it stays the same. Like it stays at 100. Let's say. Now, if you want to know, how do I say it? So if you want to know how radius affects flow, you have to look at how radius affects resistance first. And the resistance formula, it's like that viscosity, I think, over viscosity is here and radius is here to the power of 4. Just know that radius is to the power of 4 is inversely proportional to resistance, right? So you want to know what happened to pressure, you would do pressure difference is equal to force times resistance. Force times yeah. So wait, just a second. So it's like, how do I say it? But like I said, remember, pressure is always in directly proportional to resistance. If you follow that formula. So just know that how do I, yeah, so radius to the power of 4, if it's doubled, right? If it's doubled, that means 2 to the power of 4 is 16. So any changes you make in the arterioles, any decrease or increase, like doubling or like decreasing it, you would affect the resistance by like 4 times, like to the power of 4, whatever the value is. So since it's double here, you're increasing it actually to 16. Is that clear? I wanted to get the formula here, honestly, but I don't know if I have it. But for now, is that clear for everyone?
We can add the
Let me try.
slides,
Yeah, let
yeah.
me try explaining it from the formula.
Wait, is it clear for everyone?
Yeah, let me know if it's not, because I want to.
We can come back to it later because we have a lot left.
Oh yeah, that's true.
Right.
If it's not, it's okay. We'll try to explain it.
Yeah, let's move on and then we will get back to it later.
Okay, sure. We'll get back to this. Yeah.
Okay, so in the image, the left ventricular pressure volume loop drawn with the solid line was recorded in a healthy patient at rest. So compared to the normal pressure volume loop, what cardiovascular parameter is reduced in the pressure volume loop drawn with the dashed line?
Yeah, so basically what's decreased from, if you compare the red to the dashed line?
E.
Someone said E.
F in the chat, D because this is as volume after systole, we decrease diastolic volume.
No, systolic.
E and diastolic.
C. Okay, it's fine. We can see what the answer is. But do you want to explain, whoever said?
Yeah.
Yeah. Do you want to explain why? I think someone did.
Said D
Less
because there is
volume,
less
yeah.
volume.
Someone said D. It's okay, we can.
Yeah.
Okay, so the correct answer is E. Yeah, as end systolic volume decreases. So the only parameter, so this is the PV, like the loop you guys know about. The only parameter here that's reduced is the end systolic volume. So you can see from so I can't point to it on the graph, but you see on the x-axis, it signifies it's talking about the ventricular volume, right? Now you can see from the red, it's 50, and you can see on the graph itself, the graph is the clue to the answer. So you can see that it decreased in volume, decreased in end systolic volume, because that's when systole finishes. That's when the heart contraction finishes. I got confused with the color. It's okay, yeah, as long as you got it. So the red is the normal, and we were asking what happened, which parameter decreased from the red to the dashed one, to the blue one. But is that clear for everyone? So for example, someone said cardiac contractility. You can't see that on the, I mean, you can't, yeah. It's not part of the parameters, I would say, like volume or pressure. I'm proud. That's good. That's good. Even if you get them wrong, like you can get them wrong here.
Yeah, you can learn from them.
You can learn from here. So it's good.
I have a question.
Yeah, go ahead.
Could you say could you point out which of the parameters reduced or increased or the same in the picture?
Okay, so wait, does this show?
Was it O?
Which one O?
Like there's O and MP.
Oh yeah. The O and MP are they're parameters also, but not, I don't know if they're volume or pressure. But basically that's when you know if, yeah, that's when the valves open and close.
If you
so
want
those
to,
are, yeah.
you could draw it out.
Okay, yeah. So we'll draw it out here because I can't. But wait, let me see. Yeah, I think. Wait, how did it look like that, right? So this is the normal, right? And it expanded to this one. So you can see here, this is the end systolic volume, because that's when the heart stops, like, so the heart, like the contraction of the heart goes in a loop like that, all of this loop. So this volume signifies the end systolic volume.
Yeah.
This
It was
when
50.
when it was 50, right? And then here this parameter is end diastolic, so it didn't change. Whoever said D, I think it's fine, but just know that in this question it didn't change because it's the same volume, right? M is mitral valve open. Yeah, so wait, where's M? Here. Yeah, you're right. So all these points you see here are valves opening. So here is mitral valve opening, here closing, and then aortic opens, and then or aortic closes, right? So the rest of the parameters, I think they're fine, but the only thing that's reduced here is the end systolic volume. So stroke volume is the area of the curve or the graph. So it increased, like you can see, this was the one before, and then this is the one after. So stroke volume increased, but it didn't, like, since, yeah, but that's one of the parameters. Let's see, another one. I think even contractility. Yeah, I think that's all. Is that clear?
You're saying, do we have to understand
Oh.
the line? The straight line you can ignore.
Yeah, you can ignore that
Just
one.
look at the PV loop.
Yeah. But I think that would be compliance or something, right? Pressure over volume.
Yeah.
Volume over pressure. So it would be the opposite. Yeah, but ignore the straight line.
ESP.
And systolic. Do you have to, yeah, wait. Do you guys have any questions for this? But basically just look at if you want to look at the parameters, just look for end systolic volume and diastolic volume, the valves opening, closing, and the stroke volume. That's it. Is that okay? Oh.
Is it clear?
Okay, good. I hope.
Yes, thank you so much.
No
Okay,
problem.
so which of the provided images is correctly labeled for the electrode placement and polarity of the 3 standard limb leads?
Until now, everyone said B.
Because
I feel like
that's
you can't explain it, right? Yeah.
Exactly, guys. It is B, and it's just the way it is. So yeah, this is literally out of your slide. Common sense as med students. Yeah,
I guess.
this is just out of your slides, and it's really important to know. So just memorize it because he could easily like get it for you. Okay. Also, just move
Are we
on.
good? Yeah.
Love the hard to read.
We can move on?
Yeah.
Since everyone got it right. Okay, so during the physical exam of a 63-year-old
like image
male...
like show.
No, I'll show it later.
After?
Yeah, after. So 63-year-old male patient, simultaneous heart sound auscultation and carotid pulse palpitation are performed. A low-pitched heart sound is heard just before the carotid pulse is felt. Which of the following heart sounds is most likely heard? Sorry. Most likely heard. D. Wait, do you want to explain what S4 means to you, or split S1 means? Because it is before S1 and S2. That's right. The S4 is before S1 and S2.
S4 sounds because it comes right before the closing of the mitral and tricuspid valve. Fair.
Yeah.
Okay, so the right answer is D.
Yeah. So good job. this is the picture. It's not that clear, but you can like appreciate the lines, right? So you have the red line is the ventricular, like the volume pressure curve, and the one on top, the dashed one, is aortic. But basically the main thing from here is the valve sounds and their places. Okay, so S1 is what you hear when the mitral or the tricuspid valve closes, and then the second sound you hear is when the aortic or the pulmonic valve closes, right? That's right. Like we all know what S1 and S2 is. Now in this question, what they're doing is they're feeling the pulse and like auscultating the heart at the same time, right? So when you do both of that and you hear the sound before the pulse, that means that like someone said in the chat, that means that the valve, like the sound is heard before the closing of mitral or before the closing of tricuspid valve. So basically before S1. So you're hearing this sound before anything else, which is like abnormal in a way. So that would be S4. So S4 happens usually in concentric hypertrophy, which means that in hypertension, like high blood pressure, the left ventricle starts to undergo hypertrophy, which means muscles, like there are more muscles in the left ventricle to accommodate the high blood pressure, right? So that's why the blood hitting these walls makes S4 sound before you even go into systolic, like before you even go into S1 and S2. Is that clear? So the keyword here is before the pulse is felt. That's why that means, oh, you know that, oh, it's before the blood goes from the heart to the artery. So before S1 and S2. Is it clear?
Yeah, it is.
Is it?
I think so.
Okay. Okay. If you don't, just let me know.
Thank you
Okay.
for explaining.
Yeah, go.
Okay. So basically, your patient's ECG, it shows a negatively deflected QRS complex in lead 1 and a positively deflected one in lead AVF. Using the 4-quadrant method for determining electrical axis, you determine that he has a...
Everyone, let's see. See,
because we see... What do you see?
What do you see? Oh, like the...
Because a negative lead one means going toward the left. My future, it's a rhyme.
Oh, okay.
So basically, as you guys said, it is C. So depending on the quadrant method, we have basically the normal one where the lead one is positive, so it's up, okay? The QRS is up, and the lead AVF is positive too. So both of them are positive. That's what we normally see in basically a healthy patient. But if we have right axis deviation, what will happen is that lead one, the QRS are going to deviate down rather than up. So this is going to be negative. So they're going down and the AVF is going to stay normal. Okay. So that when we see the lead one is down and AVF is normal, that's how we know that it's basically a right axis deviation. And if we have basically the opposite, lead one is normal and AVF is downward, then basically this is left axis. You could just know it by like the way how, like if lead one and AVF are looking to each other, that's right. Okay, like they're meeting to each other, so that's right. But if they're away from each other, then that's left. Okay,
that's how we memorize it.
Yeah,
it's okay.
Yeah, so basically, yeah, it's like when they're together, they're meant to be, so they're right. But then when they're away of each other, they left each other. You get me?
Okay, good.
Yes, it's clear.
Okay.
Perfect.
So which of the following heart murmurs is only heard during the diastole? I think it's clear.
I think it's clear. Yeah, I explained all of it, like the one before. I don't know why I got another one. Oh, okay. I see the difference. So here it says only heard during diastole. Okay, someone said C. C, C.
The boy C.
I think
It's kind of obvious.
B, I don't know. Yeah, that's true. It's okay. So remember what I said. Okay, someone
Because
said.
in
Yeah, yeah,
dystole, the valve stenosis would cause a sound while the tricuspid valve is trying to fill the ventricles.
yeah.
True.
That's but if there's something abnormal, you'll hear it because when
Goodness.
relaxing tricuspid, yeah. So
It
when
will open,
relaxing,
yeah.
yeah. So good job. Like you got why it happens, right? So during relaxation, again during diastole, you have blood flowing through the tricuspid, but when they're narrowed, when they're not like fully open, that's when you hear the sound. Wait, someone said.
Let the teachers
But good job,
explain.
honestly, mashallah, that's really good. And then the one thing that's new here is patent ductus arteriosus and intraventricular septal defect. Both of these are heard throughout. So even if you hear them in diastole, you'll just hear like a hollow like you'll just hear the same kind of murmur throughout the whole cycle, the cardiac cycle. Why? Because patent, like they're even like septal defects or ductus arteriosus, they're just open throughout the cycle, and like they're not supposed to be open at all. So that's why you just hear it throughout. Is that okay? Okay, clear. I feel like this is clear, right?
Yeah.
So if we can move on, is there a way we could determine if it's D? You mean D from A? Okay, so there are ways. If you mean D from A, oh, ASD. Oh, you mean like VSD, ASD. So atrial septal defect, ventricular septal defect. They're in different locations. So when you auscultate on the heart, for example, ventricular septal defect, you'll hear it on the. This is extra info. You don't need. I don't think it. I think it's too early for you. But so when you have ventricular septal defect, which is a hole in the ventricle, okay, you'll hear it's just like hollows, like you'll hear it throughout this cardiac cycle, but on the left sternum, so left side of the sternum. But for example, if you have atrial septal defect, which is hole in the atrium where it's not supposed to be, you'll hear it in, I think, in the pulmon, so it's higher up. That's it, based on the location. But again, I don't think they expect you, like they expect you to know, so it's fine. Okay, that's good.
Okay.
If you guys don't have any more questions, yeah, we'll move on.
So a patient has a long QT syndrome and a pharmaceutical drug makes a drug that wait, what?
That opens. What?
Oh
Wait.
yeah. So basically he has long QT syndrome and then he was given a drug that opens the inactivated sodium channels, okay, to cause more contraction. Which of the following phases would the drug work best at?
This is, yeah, no, it is. Phase 0, because that's the only phase where sodium is involved anyway. A0. I think this was like.
Wait.
Yeah, I'm trying to read it too. Oh, it is the only. Wait.
I think there is a mistake.
No.
Wait, I want to check something here.
Aren't the channels inactivated? Yeah, okay, wait.
Aren't the channels inactivated
I don't want
in
to say.
phase 3? What do you guys think?
Yeah, so be
That's a
careful.
good
Even
idea.
if phase 0 has only sodium, it says inactivated. That's the word.
Yeah, so basically,
It's fine, search for audio.
wait. Yeah, I want to.
Oh, okay.
I want to just check something. So QT. So guys, he has long QT syndrome, okay? And then what was given is basically like a drug that opens the inactivated sodium. So if you think of it, okay? So phase 1, how many questions left? There's a lot.
No, wait,
It's
no,
not that much. No, we
isn't
have
it ECG
at the end, guys. We have like a we're going to like go
Yeah.
over all the ECGs.
I think
So
there's
basically,
oh wait, sorry.
where is
I thought
okay,
it was-
guys. So basically, the answer is It's phase 4. No, phase 3.
It's okay.
Wait, in here it showed phase 4.
Yeah,
No?
yeah, yeah. It was wrong on our slide, but it's phase 3. Like it's where the sodium channels are inactivated.
Yeah.
Yeah.
So basically, remember where, like, so where do we find usually the inactivated sodium channels? Remember how, if you guys, any of you, like, watched my cardiac physiology in the first, like, an F&D, where we talked about, we have, like, sometimes the sodium channels are inactivated where they do not open at all. Okay, so which diagram is this? Wait, let me go back.
Yeah, go back. It's okay. It was like shown way back, but
yeah, in here.
yeah, there.
Yeah, literally here. So basically, QT, it corresponds, like, can you see how, okay,
Yeah,
let me draw it. So basically we have, this is the P, the QRS, and then the ST. So basically the drug, what we have is the patient has a long QT syndrome. So his QT is prolonged. And we said basically that this is 0, 1, 2, 3, and 4. So basically this corresponds to 2 and 3. Okay, so what happened is that QT is prolonged and we want it to be shorter. We don't want the patient, because if he has long QT syndrome, this is going to affect his health. So what happens is they gave him like a drug that opens the inactivated sodium channels. Usually the inactivated sodium channels are in here. Okay, so remember how we said in phase 2, the sodium channels are like not even inactivated, they're disabled, they can never open in phase 2, and that's when, like, that's why we have a long refractory period. Do you remember this from, like, the normal cardiophysiology?
Yes.
Okay, so basically in here we're saying that we want to target the inactivated. So the inactivated sodiums are usually here. So basically if they open the sodium, this phase number 3 is going to be affected and it's going to shorten the QT. You get me? So basically after the 3, so it's not going to be like it's kind of is like this, like very long now, but when we give it, it's going to be like kind of faster. So the QT is not going to be as long as it is. Okay, is it clear? Can you ECG?
Yes, it's clear. Got it.
Oh yeah, at the end.
Yeah,
like
we have,
ECG.
yeah, all the ECGs are covered at the end.
Okay, good. That's good.
Okay, perfect. Okay,
Wait,
we went way back.
Yeah,
One
it's okay.
second.
Wait. Yeah. It's the one with this question.
Okay, perfect.
Wait, oh yeah, here. I keep getting scared.
Okay.
Okay, so in the image, the black dotted line in each of the 4 shows the PV loop of a person with a valvular heart defect compared to the one in red, which is healthy. Which of the panels represents mitral valve stenosis? Again, for the valves.
Yeah, I saw.
D. So yeah, this is basically D, someone said B, but yeah, for the PV loops, just know which valve, like pathology, correlates to like which graph. Okay, D for bad.
So the right answer is D.
Yeah, it is D. So
do you really have to explain this? We explained it so much.
Honestly, yeah, for mitral valve stenosis, it's like
you guys look at like okay, mitral, like where does the mitral valve usually open?
Open here, yeah.
Stenosis is narrowing, right?
Yeah.
So basically, it usually opens like right here, right?
Like wait, I can draw it if you want. Okay. So this is the loop, right? Mitral valve closes here, but it's open here. Okay. Now this is the abnormal compared to the normal. Wait, this is the abnormal compared to the normal. Now since there's narrowing, that means that not a lot of volume goes out to from the atrium to the ventricle. So that's why you have less. And basically nothing more changes than that. Yeah, the stenosis is the point where 50 is.
I mean the mitral valve.
Yeah, you're right. Where 50 is. Now someone said B, but okay, B is, so the abnormal thing in B is it goes way beyond, like the volume goes a lot more than the heart can hold. So it's not a stenosis problem, it's more of regurgitation. So C, for example, is aortic stenosis. And again, it's important you know how to differentiate between the four. I used to just like memorize which one was which, but also try to understand, like I said, like that's volume for, especially for mitral stenosis and aortic. So they'll try to get that. They'll be like, oh, preload is decreased in mitral stenosis and so on. Okay, preload. What I mean by preload is the volume. That's why. Is this clear? Like, is this clear?
Yes, it's clear.
Okay, so just make sure you know that. No, this is the next one, right?
Is this the next one?
Yeah, this is the next one.
I feel like you're gonna kill us.
Yeah, I forgot.
There's a lot of these.
This is yours.
It's mine?
No? Is it mine?
Oh yeah, it's mine. So basically a diagram shows pressure
Okay.
changes of the left atrium, left ventricle, and the aorta. So during one cardiac cycle, the 7 phases of the cardiac cycle are labeled on the diagram, during which phase of the cardiac cycle is the largest volume of blood pumped from the left atrium to the left ventricle.
Yeah, wait, it's not as hard as
Easy.
But someone said phase 6 because it is rapid ventricular filling. 6. Do we have other answers? But yeah, the main question here is in the last sentence, so largest volume of blood. Okay. Do you have other answers, or I think is that it? I hope that means like it's clear. No, I don't know. Okay,
He's right, yeah.
Okay, good.
Yeah, it's
So it is
pretty
6.
clear.
Yeah.
Yeah. Next.
Okay, it is clear. So yeah, that's when it, the largest volume is pumped. Now the next question: a decrease in which of the following tends to increase pulse pressure? Again, hemodynamics. But which of these correlate to increased pulse pressure? A decrease in which increased pulse pressure. Someone said C. So I'll say what pulse pressure is in case, but pulse pressure is basically you're subtracting, it's the difference between systolic and diastolic volume, right? Okay, someone said C. D, someone said D. Okay, so I'll explain because most said C. The correct answer is C. Yeah, okay. So let me try to explain it. Wait, so do you remember the compliance formula, which is in hemodynamics 2, if I'm not wrong? So we have vascular compliance can be determined by either volume or pressure. So compliance is volume over pressure. The more the volume is, you have more compliant vessels. So the blood vessel is able to hold more, right? If you have less, so less pressure, that means the blood vessels are kind of like, it's holding more blood, it has less pressure, it's easier to hold, so it's more compliant. They're inversely proportional. Now, the reason I got this is because compliance is always indirectly proportional to pressure. Even if they say pulse pressure, they mean the same thing in like in terms of arterial compliance. Okay, arterial vessels. Is that okay? So that's it. Like that's from the formula. Just know pulse pressure. So let's say there's a decrease in arterial compliance, which means you have the arteries are very like they don't want more blood, so they're like very very narrow. Okay, that increases the pressure. That increases like the pulse pressure in general. Now we're talking about arteries, like we're away from the heart, so don't think about like increased pressure with, from the heart. But did you get that? I hope that's clear. but stroke volume would increase. It would increase. Okay, it's clear. So it would increase pulse pressure, so not stroke volume, not systolic pressure because it's the pulse pressure itself, right? Okay. I hope that's clear. Inshallah. Someone said D, venous return. A decrease in venous return would mean less blood in the heart, so less pulse pressure, so less systolic blood pressure, so less, everything's less, because not a lot of blood is going back to the heart anyway. So I hope, inshallah, that's clear. Do you guys have questions for this question, for this question? So that's it. This is the main idea. Okay.
I think we can move on.
Yeah. Go ahead.
Is it venous return the same as volume in the equations?
Return. So when we say venous return, it's not the volume. You would name it, you would give it another name. You would say central venous, not volume, yeah, central venous volume and central venous pressure. It's not the same, but just ignore, just cross that out if you see that in the question, because it's not related. Okay. Oh wait, you answered the next one. Good. Okay, when propranolol is administered, blockade of which receptor is responsible for the decrease in cardiac output that occurs? So which receptor basically decreases the cardiac output? A, because a decrease in A1 receptor would mean the entire cascade that increases cardiac output. Okay, increases cardiac output. If someone said B. Ooh, wait.
So is it A or B, guys? Hello, fight.
Give me a reason.
B for boys.
For B. What's your reason for B?
If B is for boys, I would go with A.
No. Okay, I think most are saying B. But there's no reason. Okay.
So give
It's
us a
fine. I
reason.
think it's memorization from this one.
Am I crazy? You're not crazy.
No. Wait, we'll explain it. Okay, everyone's just saying B.
Okay,
So-
wait, but what is A1 for? Like, what does it usually do?
He explains it.
Vasoconstriction.
Yeah, you're right. Yeah. Vasoconstriction of the peripheral vessels, right?
Exactly. So if it
Okay.
causes vasoconstriction, how would it decrease the cardiac output?
There you go.
That's my
Wait, is
question
that
to
clear?
Sad.
I was going to ask you to, but I hope that's clear. Okay, so the correct answer, like everyone, like all of you said, is B1. But you all know, yeah.
B for boys. No, I don't accept that.
Yeah, I guess.
B for Barbie.
That's good. But one thing you can memorize before, yeah, better one. That's true. So one thing you can memorize to make it easier for you to memorize is so which receptor again? B1 is for the heart, and it if you're blocking it, it decreases the cardiac output. Okay. Alpha 1 is usually mainly for the blood vessels periphery. If you constrict it, it's not going to decrease cardiac output. Okay. Beta 2 is for the lungs. So you have 2 lungs. So beta, I'm pointing to this camera. So if you have 2, so you have 2 lungs, right? So that's beta 2. Beta 2 is mainly if it's stimulated, it relaxes the like the lung, like the vessel. But beta 1, since you have one heart, that's your answer. Muscarinic and nicotinic is not here. It's like for sympathetic action. Okay. The neurotransmitter for beta 1 is epinephrine, right? Wait, did anyone ask? Okay. It is though. Yeah, epinephrine and norepinephrine, right? If I'm not wrong. Let me remember. Yeah, I think it is. But did you guys get the question itself? Wait, let me say.
We can move on and then we
Yeah,
can...
but is the question clear though for everyone? Oh, yeah, okay.
Yay. Okay.
Go ahead.
So on the
I'll
following diagram, point X represents, where's the diagram?
where is it?
There's no diagram.
No. Wait.
Okay, we're gonna skip this. There's an
Wait,
orange
let
and a
me see. Oh my
purple.
god, they didn't. Anyways.
Okay, we can come back
skip
to it
this.
later.
It's okay now. Oh.
It's fine, guys. She was okay. We can ignore.
What?
it.
Okay, wait. Just the point for disconnect.
Yeah.
Okay, so I can't.
You know, we can
Okay.
add the figure later.
We'll add the figure later, but basically, if you're giving a positive,
You can
I
draw
just-
it. Do you know how it looks like?
I don't know if this was. Oh,
Wait, what did I do?
can you see?
Oh
this?
my
Oh,
god, you can draw in this.
Oh, yeah. Okay.
Okay.
Just a second. Where's the pen? This one.
Okay.
Okay. So I'm trying to remember what the. Oh, okay. I remember. So it was like that. Okay. You can see this. Yeah. So, can you draw the diagram? Yeah. Okay. Wait. So, do you all remember? Can you use the dark? Okay, sorry, my bad. Here you go. This one. So you have a diagram in your lectures for cardiac output and venous return. Just remember that. Wait, I'm trying to remember what the diagram was.
We can
But
add
it
it at
was-
the end if you want.
Yeah,
Just
we'll add it
review.
in the end. But basically, if you see something that increases contractility of the graph, for example, so it was like that, right? So that's your cardiac output and venous return graphs. Now, cardiac output is the work done by the heart. Venous return is blood pumped by the back to the heart, and you have a normal value. So for this one, if I remember, it was contractility increases. Why? So it increased
So
it
guys-
increased on the graph itself, right?
If
yeah.
if contractility increases, why do you think? Why would it happen?
Only contractility without affecting venous return, like before it affects venous return.
Yeah. So basically, only the heart is pumping faster. The blood is not circulating faster. So basically, first of all, let's go A, B, C, D, E. So A, she began exercising. If you think of exercise, usually we're gonna have increased venous return. It's not only gonna be cardiac output. So what
True.
happens is both of them are gonna increase. So we remove A. She was in severe pain due to peripheral artery occlusive disease. Peripheral artery occlusive disease would cause restriction of the artery. So it's gonna increase the venous, it's gonna cause more pressure on the heart. It's not gonna cause increased contractility to the heart.
Yeah.
Okay. She suddenly
Suddenly
stood
stood
up.
up.
This is orthostatic hypertension, and it has nothing to do with this.
Yeah.
Orthostatic hypertension, we're gonna have decreased venous return. Okay, and then she
Wait,
was
increase,
given
I think.
no decreased venous return. That's why it.
No, like normally it increases. If
Oh.
it's abnormal, it causes
Yeah,
hypertension.
exactly.
Yeah. But you're
Oh, so yeah. If she suddenly stood up, usually venous return increases.
Yeah.
But if she has orthostatic, it would decrease. And then she was given a blood transfusion. This would increase the venous return because we're gonna have more blood. So the only thing that would only purely increase the contractility of the heart is the inotropic drug.
Okay.
Is this clear?
Is this clear for everyone? Just make sure you know what this graph is. So if it moves up, if it moves down, if the point, yeah. So if the point itself moves like on both curves, that means you're doing something else. Wait, can you delete this? The picture? Yeah. Okay, that's it. But if it's only purely contractility, that's your answer.
I think it's kind of easy.
I'll add the diagram. I'll remember to add the diagram. Sorry.
Okay. Skeletal muscle tissue can undergo tetanic contractions, but cardiac muscle tissue cannot. In comparison to skeletal muscle, what mechanism prevents cardiac muscle tissue from producing a tetanic contraction? This is super easy. Like extremely easy. I went really easy on you.
Yeah,
guys.
yeah.
B for board. Ouch! That hurts.
That hurts more than B for boys. B because the long.
Wait, B for board. Wait, no.
Let me. Okay, but I just want to say good job. So B because
it's
the long
refractory.
oh,
this is so easy
refractory.
to explain, yeah.
Yeah. You're right.
But since we have this, I wanted to explain the question we talked about before. Remember this question where we asked which phase, if she was given a drug, and then we asked which phase would activate the inactivated sodium channels. So basically, if you guys look here, the idea of that question was that basically we wanted to kind of cause a new contraction during the relative refractory period. So we know basically in the absolute refractory period, there is no way that an AP can be generated. Okay. So
okay,
where's
yeah.
the pen?
Here.
Yeah. So basically during this phase, okay, the ARP, there is no way like a new contraction can be generated. And usually here we have calcium, right? Okay, so basically the question said that they wanted to activate the sodium channels, and we know that basically sodium equals depolarization. So the question is just literally trying to test you on the relative refractory period. So basically they were asking like, okay, if we did give the patient like a drug that would open this inactivated sodium channels during a contraction, where would it be? It would be in phase 3. Why? Because it's in the relative refractory period. Is this clear? Like this is related to the like the long QT and how we want to manage it. Okay, perfect.
Okay.
Next.
Next.
So the low resistant pathways between myocardial cells that allow the spread of action potentials are This is like a joke, guys. Yeah.
I hope it comes in the. Oh, you said. Oh wait, someone said A. What's the answer?
Yeah, it's easy, guys. Go check.
Just know that for the heart.
Okay, so
Next.
the cell-to-cell conduction of a wave of depolarization through the AV node of the heart occurs through which of the segments? So each, like you see how like 1 corresponds to this, 2 corresponds. No!
Oh wait, someone said 2 before you. Anyways.
No, I want someone to explain.
I want someone to explain, yeah, before she does.
I'm gonna cry.
Oh shit, no.
Okay, no one saw. Wait, what happened? Anyways, guys, let's act like nothing happened. So what would you think the answer is? So basically, which like part of this corresponds to the AV node?
Yeah, nothing.
Shouldn't be none of them because technically it should be the PR segment, not interval, right? So basically, okay, you have a point,
Yeah.
but basically like PR is within 2. So this is only P and this is PR. So because PR is within 2, you can just say, because if you see like, okay, like, do you get me? PR segment is when AV is transmitted. Yeah. So basically we know that basically PR is the atrioventricular like how the wave is traveling. So in here it's just the atrial contraction, and then in here it's going to be transmitted into the V. So basically this is kind of the like the PR. Okay, sorry, this is RR.
It's okay.
So the PR, so it's part of 2. So you could just answer 2. But if they only like said this is 2, it would have been like more right. But you get me? Or did I confuse you guys?
I think it is clear.
Is it clear? Do you have it to repeat or is it clear?
It makes sense. Okay, it's clear.
Yeah, and here even you can see it here, guys. So this one here corresponds to the AV. Like you see, this is the AV, and it literally corresponds to this part. Like, can you see that this is AV? This is AV, and it corresponds to P. Okay, wait, my handwriting is horrible. It corresponds to like the P here, and then here. So it's kind of the segment, which is number 2. Okay? It makes sense if you think about it. Yeah.
They think it's clear.
Okay. Now we start ECGs.
Yeah.
Okay, guys.
Yay. Okay. Go.
So let's look at this together. So do you know, guys, what rhythm is?
What
rhythm? So basically the rhythm is like okay, let's screenshot this so it's easier to explain.
Pattern, regular.
Exactly. So the rhythm is like if I want to check the rhythm of a QR strip, I look at the like you can see this is 1, 2, 3, 4, 5, 6. So we have 6 QRS or like the full one. So are they equally spaced away from each other? Like do you feel like oh they're kind of like equally spaced? Yes. So even if you count them, like you can literally count between like a
The
P and
boxes.
another. So basically
Yeah.
this is, let's say this is the start of a P. So 1, 2, 3, and about 4, the start of another P. Let's count another one. 1, 2, 3, 4. It's kind of regular. So exactly. So the rhythm is regular. Now rate. How do we calculate rate? Do you guys have the trick?
This is normal sinus.
4 big boxes. Exactly. So we divide 300 by the number of big boxes. So we have 1, 2, 3, and 4. 3 divided by 4 is 75. So as we said, the rhythm is regular. Okay, the rate is about 75. What is the QRS duration?
So QRS.
So we know that each small
Like-
tiny box is equal to like 0.02, right?
Just say if it's normal or not normal.
Yeah,
like
do you think the QRS duration is normal?
Oh.
I think I can zoom.
Oh yeah, okay. There you go.
So if you can see it, it's about 2 small boxes, and that's usually what a normal QRS wave is. It's usually 2 tiny boxes.
Or I think
or
2,
up to 3, I
3.
think. Yeah. So basically, we could clearly see that the QRS duration is normal. So the P wave, is it regular? Do we always see a P wave before a QRS? Yes. Okay, so the QRS duration, it's normal. Okay, and the P wave, it's visible. Now the PR interval. So basically, how many number of small squares does a PR interval have to be for it to be normal?
Yeah, I used to think 3.
Yeah, it's usually less than 5. And if you could see here, we have like 1, 2. So it's normal. So we have a normal PR wave. Okay, so here, guys, what do you think this is?
What's the
Like, what do you think this strip stands for?
You were all like you got
Normal
everything right.
sinus rhythm. Yay!
You got everything right. So here.
So guys, this is the basis of literally the ECG. So you have to memorize how this looks so you can compare it to everything else. Okay, so the rhythm is regular. The rate is basically usually between 60 and 100. This is the normal rate. The 83 here is wrong because this picture is not from your slides, but I got the description from your slides. So never mind the 83. The QRS duration is normal and it's usually about 2 to 3 like small tiny boxes. The P wave is visible. That's very important because if the P wave was absent, that's ventricular fibrillation. If it was if it was there
absent,
but like longer and stuff, or if it's there and we have a lot of ones before the QRS, that's atrial fibrillation. So is this clear? Is the sinus rhythm clear?
This is like the
This is like the basic.
yeah. You might get it. Like
they might just get it and be like, oh, describe
but
it.
usually
Like it can be an SAQ. They can get it and be like, oh, can you describe the rhythm, the rate? No.
Yeah.
Anyways, so I was going to give you the trick, but you guys already know it. So usually what we do is we divide the 300 by the number of big box squares between the two.
2 are. So I even it's fine.
What's that?
Wait, what do you want?
I want a screenshot. Yeah, so basically we look here. Okay, so we look at the R's. Usually it's either R or P. Whatever, you know what I usually do? I usually go and find one that starts at wait. None of them are amazing, but usually some of them like one of the R's, if they start like at the line, okay? So that's when you can start counting. Like even if مثلا, you don't really have to start from the first one. You look for like, let's say the R that is at the straight line and you start counting until the next R. Okay?
I used to do with R's.
Yeah.
They're the easiest.
Or P, it's the same thing.
yeah.
Okay.
So like,
Okay. So we're talking about rhythm. And we know that basically we have three different types of rhythms. We have a regular rhythm, we have an irregular rhythm, okay? And we have a regular irregular and an irregular irregular. It sounds funny, but what does it mean? So basically, regular rhythm is a rhythm that we see. The sinus rhythm is a rhythm that, oh, it's like always there, okay? A regularly irregular, like, okay, we can see something is wrong, but it's kind of regular. Like I can see, let's say there is an absent P wave. We don't have a P wave, but each single one does not have a P wave either. So basically, this is irregular, but it is regular.
we'll match them later.
No,
on.
yeah, this is a match. Like we're gonna match them now. But I'm just trying to explain. It's a game that we're gonna play now. But I'm explaining the.
But I think it's like
so basically. The regular rhythm is the normal sinus rhythm. Everything is perfect, everything is normal, and it's happening regularly, okay? The regularly irregular, so basically we have a pathology, we have something that is wrong. The P wave is absent, the QR is prolonged, the QT is long, but it happens in every single heartbeat. So basically it's irregular, but it's regularly happening, okay?
Yeah.
Lastly, we have irregularly irregular. So irregularly irregular means that basically it's irregular, and this irregular thing is happening in an irregular way, if you get what I mean.
Yeah.
So basically, let's try to match these together.
Oh.
Wait.
It's okay. So wait, someone already said it, but
okay. So basically, first one. What do you think this is? So let's look at the QRS. So we have basically, we can identify, let's look here. So when you look here, we have a P, a QR, and like this is 1, this is 2, this is 3, this is 4, 5, 6, okay? So you could see that, okay, the P wave is there, QRS is there, T is there, everything is there. But what we have is, basically here, we have a prolongation. Okay, so do you think this is regular? Let's start with, is it regular or irregular?
Irregular.
No, before,
right?
before okay.
Classifying.
Yeah, the first, before putting, okay, there's 2 words, right? So forget the first one, the second one. Is it regular or irregular?
Irregular, shouldn't be there. In the
do you think this is normal?
Regular rhythm, regular.
Okay. No, wait, is this normal? Do you think it's normal, guys?
To have a...
Okay, it's irregular.
Irregular.
Exactly. So basically, we start with the first one, which is, this is irregular. Okay? But this irregularity, is it normal? Do we keep on seeing it? I know it happened once here, but it happened again there. But you can see there's 1, 2, 3, and then it happened. 1, 2, 3, and then it happened. So is it regularly irregular or irregularly irregular? Don't try to identify what it is. I don't care what it is.
Type 1. Regularly irregular.
Regular.
Yeah.
Exactly.
Yeah.
So basically it is irregular, but we can regularly see this not normal thing, my mouth. Okay, so basically it is regularly
irregular.
Exactly. Irregular. So we know it's not this is not the normal. This is not the normal sinus rhythm, but it's kind of regularly happening, okay? And it's my bad. I should have got one that is longer. But you could see here that the basically the QRS drop that you were guys talking about. Some people are trying to join.
I'll tell them it's okay.
I think we can accept everyone though.
Oh, okay. There's no one.
There's no one in the waiting room.
Just send this link, I think, on whoever. I don't know.
Wait. Is that from here?
No.
Do I accept people from here? No.
But you don't see it. Yeah, there's no one. Just let us know.
Oh my god, there's 388 messages.
Yeah, yeah. We have it open. Okay.
Okay.
So the first one you guys
So
got,
the first one was correct.
like this one.
Okay. We'll match them at the
Yeah,
end.
and then
Okay, now this one. Let's start. Do we see a P wave? Like, do you see like a normal PQRST? No. So do you think it's regular? No.
good.
So basically it's irregular, right? Okay.
Sure.
Yeah. So basically it's irregular. And do you think there's a pattern? Because I don't see a pattern. Like, okay, we have one, and then we have and then two, and then the same thing, and then three, and then ooh, like you see, like
Yeah,
even the interval, like okay, this is two boxes
But
only. Here it's 3, here it's 4. So it's not regular. So do you think it's irregularly irregular or regularly irregular?
It's kind of a mess. Like
Yeah. The name is a mess.
Yeah. Also the
So guys,
just yeah, good job. Like, I was gonna
exactly.
say,
So
just say
it's
IR.
irregularly irregular. Exactly. Now the last one. Okay. Basically, we can see a P, we can see a QRS and T,
It's
and
the
they kind of
easiest.
like literally they're regular. Okay, so this is super normal, and this is basically a sinus rhythm. So this is just regular
and
regular. So
regular.
it's regularly irregular.
no regularly.
Regularly regular. Is it
But
clear?
usually for this you just say sinus rhythm.
Can
and
we
that's
get
it.
the link so we share it?
Yeah, I'll send it on. Can you send it? Yeah. Okay. So regular, normal rhythm. Good. Regularly irregular, similar abnormal pattern repeating. Good.
Yeah.
Irregularly irregular, there are abnormalities, but they do not follow.
You guys have it on your.
No, look.
This is amazing.
Let's copy this honestly and just go. Some people can end.
Yeah, can you copy it? Or we can add it to it. I don't.
Oh yeah, I'll copy your
You guys have the link on your batch group.
Outlook.
No, batch group even. Did they not send it on your batch group?
Yeah.
She texted it to them. No,
Oh
thanks to
yeah.
the
It
link.
is this.
Yeah.
Okay. We'll just.
I
keep
just
that.
have it.
Yeah.
Okay, I'll send the link 1 second.
So some people. Oh wait, is this during rest? Which one? The normal one? Yeah. It's during rest. Oh, so you
Wait,
mean
is
like,
this during rest? Yeah, so basically, okay, okay, it's here. So basically, the regular rhythm is the normal sinus rhythm, which is basically the rhythm that we all have because inshallah we're all healthy people.
Yeah.
Okay. The regularly irregular, it means that okay, we have a problem, but it's happening in a regular fashion. Like it's happening every 2 seconds or every 3 seconds or whatever. But like it's kind of regular. Like sorry, yeah, the no problem is happening in a regular fashion. But the rhythm itself, it's irregular. Okay? Last but not least, the irregular. That's kind of obvious. Now,
do you want to like no, we can do it, right?
Yeah.
Yeah.
Okay. So guys, what do you think
Again,
the rhythm?
for this one, rhythm.
How do you see it?
Tachycardia, someone said.
Tachycardia, cool.
Regular.
Okay, let's take it step by step before just jumping into it. So basically, the rhythm, what is it?
Just go like for rhythm. I was okay.
Guys, don't.
It's
Yeah,
fine.
okay. So the rhythm is normal. Or basically it's RR, regularly regular.
Yeah.
The rate, can someone like calculate the rate?
Or like just estimate.
Or like estimate it.
Boxes.
So usually how much is the rate?
Is it too fast? Is it too
130-ish. Okay, it's 130-ish. So basically it's just more than 100.
Yeah.
What is the QRS duration? Let's zoom in.
Yeah, there you go.
It's literally only 2 bucks, so it's normal. So the QRS is normal. Okay, so what about the P? Is it normal? Like, do you kind of see the P every single time? Yeah, we do. Here is a P, and so on.
Good job.
So it's there. It's normal. And the PR interval, which is it's usually less than 5, like less than 5 or 0.2. We can see that it's like 1, 2, 3. So it is normal. So everything is normal. Just the only problem is that the rate is very high. So what do we call this?
Like someone said it first.
It's sinus tachycardia.
Yeah,
But it's
good
really
job.
important to say sinus because sinus means it's a normal, like
Regular.
it's not normal, but it's regular, you know?
Yeah.
So the rhythm is regular, the rate is like high. Okay. And the
Tachycardia.
QRS, everything is normal except for the rate, it's very high. Okay? Is this clear?
Oh yeah, you mean
Can a
he's-
tachycardia be abnormal? Obviously. Listen,
can be,
everything above the normal is abnormal. This is kind of like no, but actually, like tachycardia, it could be tachycardia could be because of
like
how
do I say it?
pain.
It could be,
If any patient has pain and they come into your clinic, they can be tachycardic. So
Yeah.
basically, tachycardia can mean like a lot of
it
things.
could be like ventricular tachycardia, right? So like the QRS would be too big or something. But this is normal.
Yeah,
like
exactly. It's very important to say it's sinus tachycardia so that it is like it's normal.
for
It's just
both,
that
like,
the rate is high, okay? Because there's something called like ventricular tachycardia and things that you're gonna take later
Wait,
on.
yeah.
Okay? Is it clear? It's easy. Next,
It's I think
the same issue.
yeah.
What's the rhythm? Is it normal? Guys, don't give me the thing. Don't
give me
say
the
what it is.
diagnosis.
Yeah, don't give me the diagnosis. Yeah, okay.
Normal. Good job.
Rhythm is normal. So it's regularly regular. RR. So the rate. Can someone calculate the rate for me? So
say
it's
if
300
yeah.
over. Let's say how many boxes are
One,
between.
two, three,
let's say
four, five,
1,
six.
2, 3, 4, 5, 6. So 300 over 6, it's almost 50.
50. Yeah, good job.
Okay.
So that's two. Yeah.
Greater
More
than 70.
Oh, it could be. It's just less than 100.
It's
Oh
less
no,
than
no, less than
60.
60. Yeah, it
It's
should
less
be
than
less than
60.
Yeah, less than.
Okay, the QRS duration, if we looked here, it's equal to 2 boxes, so it's normal. Okay, the P wave, do we see a P wave before everything?
Yes, we do. Yeah, seems normal. Good.
Yeah, so it's normal. And the PR interval, like from here to here, it's kind of normal. So the only problem is that the rate is lower than usual. So what do we call this?
What's the word before it?
Guys, the word
What's the
before
word
it is
before it?
important.
Yeah, you're right.
It's
though.
bradycardia, true, but what
yeah.
is it? Sinus bradycardia.
Yeah,
exactly.
Good job. That's it. Like that's sinus bradycardia.
Because maybe in their SAQ they'd give you like 2 marks, 1 mark for sinus and 1 for brady.
Yeah.
So you never know.
Okay, let's do the
Anyways,
same thing for
now this one, let's go step by step too.
Wait, don't. Yeah.
Sorry.
It's okay. Okay, wait. We'll start. Did it show?
Yeah. Did you see?
I hope not.
No, they did not.
They did not. Okay,
It was very fast though.
Yeah, rhythm is.
Does the midterm as in
No. But if you want to know how to like read ECGs well, that's the step you
Let's go, step by step, just for you guys. It's a practice.
Normal.
So let's start with rhythm. The rhythm is normal.
Regular.
That is true. It's regular.
Let's go with
okay.
rate.
And then rate.
Yeah.
How can someone calculate the rate? So it's 300 divided by, let's say.
You can go.
Oh, here we have an R
Yeah.
here. So basically
1,
1, 2, 3, 4. So
75.
okay,
Yeah,
perfect. 75. Now QRS is before it, the P wave, is it normal? We have 1, we have 2, we have 3, we have 4, we have 5.
Mm-hmm.
The P is normal. Okay.
Q.
And the
also-
QRS is normal too. It's like if you look in here,
Oh,
it's
wait.
like 1 or 1, 2.
Someone said kind of small. Which one?
I mean, it's the same, guys. It's just a P wave.
Oh, P wave. I used to get confused. Like if it was too big, I used to not think of it as P wave. But
It's normal in here. Don't
It's
don't
normal.
overthink it.
Yeah.
Yeah.
As long as you see one grade, like one, what do you call it?
Like one
bump
thing
before
above it.
Yeah, it's P wave.
Okay.
Don't overthink.
Now, okay, can we see the PR? The
So
PR
all this is
interval.
fine. PR interval.
Okay, so
Yeah. PR
is more than
interval
6.
is more than 5 is prolonged. Good job. Yeah, so you see the boxes here? Yeah, here.
Yeah.
Like it goes from here.
So from here to here.
PR.
No, but we said that basically it's
Yeah.
usually less than 5, right?
Yeah.
So how much is it? 1, 2, 3, 4, 5, 6.
Six.
Oh, so it is prolonged.
It's a whole.
And then in here, 1, 2, 3, 4, 5. And then in here, 1, 2, 3, 4, 5, and 6 almost.
It's
Here,
almost the
1,
same,
2, 3,
right?
4,
Yeah.
5, 6.
So we have
And then in
prolonged.
here, 1, 2, 3, 4, 5, 6. So what happened is that if you could see it, the PR is kind of like, the PR is getting longer and longer.
I don't think they
and-
can see the camera, but
Why can't they see
because of the screenshot, right? No, or no, can you?
I don't know. Okay, so basically, if you could see,
Oh, no.
it's long. It's longer than usual. So what do you guys think this is? Everything, like, okay, so basically, the rhythm is normal. The basically, the rate is kind of normal. It's 75.
QR.
It's between high. The QRS is normal. So what do you think this is? What's the problem here?
Like what's your like if you see this ECG, first degree AV block, everything is normal, but a prolonged P wave exists, which is considered abnormal. Good, that's a good answer.
Perfect. Yes, that's
Yeah.
exactly what it is. So
Time
what
for the
happened
second.
is basically everything is normal, and sometimes when you look at it, you might
go.
be deceived that, oh, this is a normal sinus, but it's not. You have to, guys, check the PR wave, because if you do not check the PR, you might think it's not, it's like a normal sinus. No, it's not second degree, because in
Second
here
degree, PR would
PR
like
would
change.
be changing. So
Yeah.
basically in here, if we said we counted them, and every single time they were like 5, 6, like all of them were kind of the same. So this is characterized as a first degree block, that okay, everything is the same, we just have a prolonged PR. So can you tell me, is the rhythm regularly irregular or regularly regular? Shouldn't HR be less than 60 for AV block?
Oh yeah, we didn't so
Not
this is-
necessarily, because this
yeah.
is basically a first degree. First degree, the only pathology that we would see is that the what is it called? The PR is like prolonged.
Yeah. Plus in second degree there's a drop in QRS complex.
That is
yeah,
true.
I think so, yeah.
Yeah.
But for me, I
But
just used to look
there is, guys,
PR.
2 types of PR
Yeah.
of type
The
2. So one of them, both of them will have a QRS drop. Anyways, let's go to the next one.
Yeah, but we'll see like with more examples. But the next one, can you comment on the rate?
Yeah.
Or wait, rhythm.
No, yeah, let's start
Rate,
with
yeah.
rhythm.
Rhythm. Is it regular or irregular?
Yeah, first of all, the first regular rhythm. Okay, is it though?
Kind of. It's like, do you see?
No.
Yeah, okay, no, it's not. Irregular.
Yeah, it's irregular. Okay. But is it regularly irregular or regular? Okay, regularly irregular. Okay, perfect.
Good.
Okay, rate. Can someone do it for
Say
me?
if rate is,
Okay, let's do it.
honestly, for these, like, yeah. You can see what,
Okay, wait. So let's just go with, oh, here, this is like, let's say 1, 2, 3.
you can
It's,
say.
yeah, let's say about like 70 or like,
Yeah. It's fine. Like, well,
okay, it
just
doesn't really
calculate,
matter. So
yeah.
let's say it's about 70 or something. Okay. And then we have QRS.
it's normal.
The QRS is normal, right? Like, okay, we see QRS here. And it's only 2 blocks. Now P waves. We have
you see?
1, 2, 3, 4, but we don't have a QRS.
We don't have
So
anything
that's
like
the
that.
issue.
Yeah.
Wait, I got a bit confused. Regular as in the time, the second part.
As in the heart rate, like how is the nomenclature, like the naming done? So irregular. Like
So basically, the regular, the first one, like we have 2. You can't see me. Okay.
Yeah.
So
I
we
know, but
have
wait.
basically, okay, listen, we have basically here regular, and here we have regular or irregular, and
irregularly.
both.
Yeah.
Exactly. So here it depends on the shape of this, and if it has any pathology, anything bad. And the irregular, is it happening continuously, or does it happen only like it happens like not continuously, like not in a continuous fashion? You get me? How do you calculate the rate
that's
in
the
a
issue.
block?
So
Yeah, so
you
basically
see the
I think
pathology, like they
yeah,
will-
I think you ignore these here,
yeah,
and you
ignore
kind of
the
only like
pathology,
so basically you count from here, you know, like you ignore this.
just ignore it, yeah, for now, like for this
But I
one.
don't think they're gonna ask you about the rate, okay? Now for now, you guys said that basically this is AV block. Progress prolongation. Okay, but do you
Second
think
degree.
it's first degree or second degree?
Second degree movement one.
Sorry, I mean, do you think it's Mobitz 1 or Mobitz 2? We know it's second degree.
Yeah,
So
Mobitz 1
it's BD2T1.
Okay, good.
It's
I
the
think,
second
yeah.
type one, yeah. Perfect.
So again, like you said, the PR is prolonged, but it's also like changing. It's also increasing.
Okay, wait,
before
let's
it
count
drops, before it
the
drops.
PR.
So
Wait.
that's PR.
Yeah. So basically in here, if you can see, it's like 1, 2, 3, 4, 4. Okay. And then in here, it's like 1, 2, 3, 4, 5, 6, 7. And then in here, it's like 1, 2, 3, 4, 5, 6, 7, 8. So it keeps on prolonging slowly,
Yeah.
prolongs until
Before the
it
whole
drops the
whole
QRS.
wave.
So basically,
Yeah.
we don't even have a QRS. Okay. Okay, that's a very important point. And then in here, we can do the same thing. We can see that basically the rhythm is normal. No, not normal. It's irregular. Why? Because we don't have a QRS here, but it's kind of is happening regularly, I think. And then we can see that, okay, the PR is not prolonged. Okay, let's count the...
Wait, it could be prolonged, but it's not progressing, like, right? It's not increasing.
It's not increasing. Like,
even
listen,
prolonged, yeah.
1, 2, 3, 4. Okay, and then in here it's like 1, 2, 3, 4, or like 5. No, I think I started it too early here. Yeah, it's
fine,
4.
it's fine,
Okay, and in here it's like 1, 2, 3, 4. So basically the PR value in here is constant, but it's constant, and then the QRS will disappear, and that's how you know it's type 2. And I have a question, guys. Do you know which is worse, type 1 or type 2?
Type 2.
Why do you think it's type 2? It is true, type 2. I'll tell you guys a story our TA told us. So basically, in type 1, the PR, okay, so let's imagine that basically the QRS is a husband and the P is like a wife or whatever. So basically, this is a story our TA gave us last year in 3rd year. So basically, the QRS is kind of getting away from her, like slowly, because the PR is prolonging. So he's going away, and then he disappears. So she's kind of anticipating the disappearance because he's slowly getting away. Okay, exactly. So and then like it's kind of slowly happening. You want to bring milk? Yeah, it's slowly happening. Like there's prolongation, and he just disappears. So it's kind of anticipated. But in here, he's always there, and then suddenly he just disappears. So that's why type 2 is like kind of more scary than type 1. It's more like dangerous, but it's fine. That's not our point. Yeah. Now next. Okay, let's look at this. We can see a P wave, and then we can see nothing, and then another P wave in the QRST, and then directly a P wave,
right?
And then nothing, and then a P, and then a P. So what do you guys think this is?
It's what, like, I don't know.
Like we have a lot of P's without their QRS.
Okay,
D3, no connection between A and P.
Yeah.
Exactly, perfect. So basically this is a 3rd degree AV block. We know that there is no more connection between the atrium and the ventricle, or there is, but not to a complete, like you can see how like the P is like, it's disorganized. Sometimes the QRS is going to be there, sometimes it's not, and so on. Is it clear? Do you guys know, like if you just saw this, you're going to directly know it's type 3?
Yeah. One way I used to like know type 3 was like you measure the difference between atria, like the P waves to a P wave and the QRS wave to a QRS wave. You'll get different rates.
Will there be questions about ECG at the end? Not really, because I think the way the questions are gonna be is that they're just gonna give you the strip. Yeah. In the exam, I don't think they're gonna like give you a question about. They're just gonna give you the strip and they're gonna ask you, okay, what is this? I don't think they're gonna go into details because that's 3rd year. So I have a question. So 2nd degree is characterized by a dropped QRS complex. So what is the difference between what's that?
Is the PR.
Yeah, it is the PR. So the only difference is that in type 1, the PR is kind of like slowly getting prolonged. So it started with, let's say, four boxes. It went to 5, it went to 6. So it's kind of prolonging and then it drops. But in type 2, the PR is constant, but we don't have a QRS. So it just like goes away. Okay? Is it clear?
Okay. So I think we have like 2-3 more questions and then we're done, but
Wait.
yeah.
Okay, guys,
I
what do you
this
think
one.
this is?
This is the last.
This is so
oh.
easy. Like we could see like multiple P's, and then we can see QRS, then P's, and then
It's the
QRS.
blah, blah, blah.
Yeah, exactly.
What do you
Atrial
call-
fibrillation. So basically, whenever you see that we have a lot of P's with no QRS, and even the P does not look like a normal P. It
Yeah.
looks like someone is just like, you know, like dribbling. It's like you know.
Yeah.
So this is atrial fibrillation. So how do we know that this is atrial fibrillation? Because the QRS is normal. It's just the P that is not abnormal. Okay. Okay.
Okay.
What
I hope-
about
yeah.
this? This is so clear
yeah.
because guys, this is, you can't make up anything. It's just like a mountains. It's just like a bunch of mountains together.
Plus the QR.
Literally,
like,
and
you don't
there's no
see-
P, there's no ST, there's nothing. It's just like woo. So this is basically a ventricular
Yeah.
fibrillation.
Wait, don't go to the next one because I want to explain the last two before we move on.
Which last one?
Like the one I stopped, the formula one. So like I'll explain it quickly so you like so they
Oh,
get it. Yeah.
okay.
But wait. But do you guys get the sound? But did you all get where's the last the notes? Like here?
What notes?
The where I can draw.
Oh yeah.
Oh it's
Yeah, you can no.
okay. The last thing I think. So is everything clear on the ECGs?
Yeah, this
hope
is
so.
this is
That's
everything
the-
for ECGs.
yeah. I think
Which
we're
question?
almost-
So I can go back to it.
Oh, it's like way before. It's fine. It's the one with the. Okay, you want to go back to it? It's the one with the flow. Okay, but so last two questions. Someone asked about beta 1 receptors being which hormone is is attached to it? Norepinephrine and epinephrine. And sometimes dobutamine, but all these hormones from the sympathetic, they come to beta 1 and all of the rest too. But next, wait, the one question we had for flow, I just want to end with that because I don't want anyone confused. Wait, where did it go? Oh, it's the one with 16, like 16,
16 what?
like the answer.
Oh
Was it way back?
no, it was not.
Yeah, it was this way. Okay, yeah, there you go. This is the last one. Are you repeating stuff? Can you explain the one after second? Okay, so you mean third degree? Yeah, we can
sure,
go
we
back.
can go back
But
to it.
this is
Just-
only from the one before, so like we don't prolong it. So wait.
Oh, thank you guys. But wait, before leaving, we need you to do something. Don't leave.
Yeah,
Please don't
yeah.
leave. Please, please, please.
I'll explain this really quickly, so inshallah it won't take long. So again, my mistake was thinking pressure. Sorry, my bad. So they're asking about how flow changes. Ignore the 100 millimeter. They just mean if they say maintain, that means it's constant at that pressure. Okay. So they're saying how does flow change with resistance? Now you guys know the formula cardiac output is equal to change in pressure over resistance, right? Now now that they're asking for flow is basically cardiac output. That's what I was trying to draw earlier. So the pressure difference, you don't care about the pressure in this question. And then over resistance. Now how do you calculate resistance? It's the 8 viscosity length over radius. Sorry, so radius to the power of 4. You don't need to memorize this formula, but just know that radius to the power of 4 is an important value. So since resistance is calculated by this formula, if you're dividing it by resistance, you basically multiply. They'll give formula.
Just know the R
no.
to the power of 4. That's all
Yeah.
that you need to know.
But
Because all of the rest are fixed.
yeah.
Like the 8, they're all
Viscosity
fixed
length, yeah.
values, okay?
But since you're dividing by resistance, so for example, these formulas, you have to memorize them. The basic formulas, Laplace's law, like all of those Fick principle, you have to know them. But this one, the resistance one, we never memorized it. It was constant. It was a constant value. Just know how our radius to the power of 4 changes. So now again, you're doing pressure difference over resistance, right? So since we're doing over resistance, you're basically multiplying by this inverse. So like from basic math, so divided by this value means multiply by radius to the power 4 constant over 8 this. So that's what I mean. So flow is, if you see from this formula, flow is directly proportional to the radius to the power of 4. So now since you're
Is
doubling,
it okay to go over the
Wait.
question?
okay, sure, yeah. I think, okay, I'll go over the question. So again, it's okay, can I have the note? Yeah. Okay, yeah, here. So the question was asking, so now this is the formula. I'll tell you what the question is. So the question is they're trying to double. They said, how will doubling this radius increase or affect the flow, right? So since we're doubling radius, that means we're doing 2 times r, and if you like 2 times any constant, right, we're doubling it. So 2 to the power of 4 is 16. So flow will increase, whatever the other values are, flow will increase by 16 times, like 16 time fold. Is that clear? That's the question. Like I tried to say it within this. So they're saying, you have a blood vessel, right? And what if you change the radius? Sorry, what if you change the radius to be double the amount? So how does it affect flow? How many times? So the answer is 16. Okay, from this, and the basic formula is again this. Is that okay? Okay. For everyone else, is that okay? Because I just wanted to fix my point here. Okay, if you have any questions, feel free to like throw it at us. It's fine. How do you do this in the calculator? Oh, okay. Now, since these were not given values, like they didn't give you an exact value, they just said double. So you just do, for this one, it's enough to do r. What's r, right? So it's enough to do 2r, 2 radius to the power of 4. So you just do in the calculator, you can do 2 times 2 times 2 times 2 if that's easier. 2r, yeah, exactly, or 2 to the power. If you're not able to do 2 to the power of 4, just do that. Okay, you'll get 16.
Guys, it's literally
is
just
that
like,
okay?
okay,
Yeah, it's
the
just like-
question,
yeah,
you
yeah.
have to ignore all the other numbers. If they say
No, I
double,
think, yeah,
if they say double, just put 2 to the power of 4. If they say triple, put
Yeah.
3 to the power of 4. If they said like quadruple, just put 4
Yeah.
to the power of 4. So this is the important part. Like
ignore
ignore all other numbers. Because usually the way it comes, it's just that gonna ask
Yeah, yeah.
like, oh, to what power would this like change? You get me?
I think he means the like how to put it in the calculator, but if you ever have a doubt, just put it like that, or you can do 2. I think it's
No,
like
it's
that's
because
right.
no, because it's like in the
Yeah,
exam
exam
software. I
soft.
don't know.
Yeah, so it's like that,
I
or
never tried it.
wasn't it like this? Like with this thing? I don't know.
Never tried it.
Yeah, I just multiply them all together.
Anyways, do you have any other thing?
They want you to like repeat.
Oh yeah,
Third
the
degree,
third
that's it.
degree. Okay, guys, the third degree.
Mhm.
Wait 1 second.
I think
So
that's the
for
last
the
one.
third degree, okay.
Yeah, here. There you go.
So for the third degree, I just want to show you something. So what happens is we can see that we have 1, 2, 3, 4, 5. Like you could see how we have like a P and there's no QRS. Then another P, QRST, P, and then no QRS. P, no QRS, P, and then a QRS. So it's very irregular and there's no, like it's regularly irregular. That's number 1. Number 2, you could see that basically we have a lot of P's, but we don't have as much QRS. So this shows that basically the connection between the atrium and the ventricle is not as strong as it used to be. So basically it's kind of like a full block because the ventricle is like kind of, sometimes it's responding to the atrium, sometimes it's not. So that's how we know it's a full block. All right? Is it clear?
Okay.
Yeah, that's it.
Yeah,
Literally.
that's. Oh yeah, that's it. That was clear.
Okay,
inshallah.
so basically, guys, we want you to scan this barcode, please, and give us your feedback about how the session was. Okay,
Whoever
and
has
we're
it.
gonna send it on the group anyway. So
Yeah.
if you can't like scan it now, you can scan it later on. But please do, and please give us your feedback because your feedback helps us like improve whatever we need to improve. and everything. Wait.
That's so cute. Okay, wait, one last
Do you
thing.
by chance have any tips on the way of analyzing the values and deciding which formula to use based on that? Like, if you have a certain way that helped.
Okay.
Honestly,
Wait, who's this? I did have it. Wait,
You
like
have?
I have a table of the name, like the rule name with the formula. So if you're talking about hemodynamics one, I can include it in this or like send it.
Will he
Third
give
year.
us 12 lead on the midterm?
No,
Like, do you think, I don't know, Sarah.
it was in third year.
No, but it was there in the
Really?
slides. Okay, guys, for 12 lead, the most important thing to know is just know which artery equals what. So basically, RCA is basically changes seen on this. You
What
get
was
me?
RCA? Yeah, it
That's
was
how,
inferior.
yeah. So basically, you look like, okay, RCA. Oh, where is it? That's it. But I don't really think he's gonna go into detail. Like, I hope so. And the reason I did not include it is that any question about it is gonna be too advanced for you.
I
It's
don't
third
think,
year
honestly,
material.
yeah.
So the only thing you can do about this slide is just to memorize the different like
Yeah.
arteries with whatever leads
Okay,
they are.
I'll send the formula like sheet
Yeah.
or like it's a table. But if you know the basic formulas, for example, flow and pressure and radius, resistance, you can substitute with whatever, like even compliance. Like if you relate one to each other, you'll be able to like connect that in the exam. So but for the rest, for example, fig principle, I just memorized it. Like I tried to understand what the formula is and I tried to memorize.
Anyways, guys, do you
Okay,
have any
that's
other
it, yeah.
questions?
If you do, you can email us or
Yeah, you can either
like, text
call us.
I was saying call us. But you can text us anytime. That's so sweet.
Anyways, thank you guys.
Thank you.
You can go have a good night. You guys
Yeah.
need it and we need it too.